My name is Matthew Snape. I work as a paediatrician and I work at the Oxford Vaccine Group, which is part of the University of Oxford. So half my job is looking after sick children when they come through emergency and onto the ward in general paediatrics, and half my job is running clinical trials of in particular about new vaccines. So vaccines that are focused on different causes of meningitis, and that's what we're going to be talking about now. And this has been topical recently over the last month or two because it has been in the news regarding a petition that was put to Parliament to extend the use of meningitis vaccines. And the publicity for this started with the tragic death of this girl whose parents in their grief at her death made her photos public of her during various stages of her illness. And I think this brought to the public just what a horrible disease this is. And I think it was quite confronting to the public to realise that the vaccine against this disease was being rationed effectively and only made available to a subset of the population. So that's what we're going to be talking about. I'm going to give a bit of background about what meningitis is and then lead on to this story here. So meningitis just means inflammation of the lining of the brain. The lining of the brain is the meninges. And if that's inflamed, that's meningitis. We've got a mic problem? No. Yep. So just like if you have an inflammation of a joint, that's arthritis. If you have inflammation of the lining of the brain, that's meningitis. And there's many different causes. Now, I'm a paediatrician, so my focus is around children, and that's the focus of this talk. And as it happens, meningitis is most common in children. It can occur across any age, but it's most common in children. Meningitis can be due to many different causes. Viral meningitis is a nasty illness, but it's not fatal. So meningitis due to viral infections, and it can result in anything from an illness that lasts for a few days to an illness that lasts for a few weeks and can cause knock-on effects for weeks to months in adults in particular, but actually it's very, very rarely fatal, and usually there's very good recovery. Fungal meningitis, it's more commonly seen in people who have problems with their immune system. And this is the one, especially as paediatricians, we worry about and focus about. Causes about 20% of meningitis are due to bacteria. These are the ones that can be potentially fatal or have long-lasting consequences such as deafness or learning disabilities. And it gets slightly more complicated. The bacteria that could cause meningitis can also cause septicemia. That's inflammation of the bloodstream. And to a paediatrician, we don't really distinguish these because both of them are the most common causes. Both of them can be fatal, and it's just really, and they're caused by the same bacteria. So it's whether the bacteria have lodged in the spinal fluid to cause meningitis, or whether the bacteria in the bloodstream to cause septicemia. The presentations have much in the way of overlap. There are some differences, but they also overlap a lot, so we don't really bother too much. So I'm going to talk about them together, meningitis and septicemia. Now, in terms of the causes, the most common causes of meningitis or septicemia in children in the UK, historically, Haemophilus influenza type B, or Hib, was a major player. But vaccine was introduced at the start of the 90s, which means that this has almost gone away. This has been a great success story, and last year there were 3 cases of Hib meningitis. That is a great success story and an ongoing success story. There's another bacteria called pneumococcus, also known as strep pneumonia, which can cause pneumonia, but also causes meningitis and septicemia. And a children's vaccine was introduced for this in 2006, which was expanded in 2009. Now, as it happens, there's over 100 types of pneumococcus. People over 65 get a vaccine that contains 23 of those types. Young children that vaccine doesn't work in young children. So they had a vaccine that's been adapted, without going into details, to work better in children. Initially covered 7 types and now 13 types of pneumococcus. And with the introduction of these vaccines, you can see along this blue line here, in children under 2 years of age, there's also been a dramatic decline in the cases of meningitis or septicemia due to pneumococcus. So this has been a success story, but not a complete success story. And this is in children between 2 to 4 years of age. So there's been progress, but the story's not over there. There are now approximately 320 children per year who still get meningitis or septicemia from pneumococcus. That number is 10 times as high as that in the elderly, about 3,000 cases per year. But we're focusing on children's meningitis here. And in the elderly, it tends to be septicemia rather than meningitis. There's another bacteria called Group B streptococcus. This is has a very specific niche, that this causes disease in newborn babies just in the first few months of life. There is no vaccines for this as yet, and you'll see on this graph that actually the incidence is actually going up, if anything, and it causes disease in about 508 neonates per year. It's the most recent data. This bacteria is carried in the birth canal, either vagina or actually also in the rectum, of 20 to 30% of pregnant women, and they can then pass it to their babies. That's why it occurs in the first few weeks to the first 3 months of life, most commonly in the first week. It affects 1,000 to 1 in 2,000 babies that are born in the UK, with a case fatality of about 5%. That means that in 2014, 2015, in the UK and Ireland, there were 38 deaths from this in newborn babies in 2014-15, in 1 year. There is no vaccine license. If to get a vaccine that would work against this, it would need to be used in pregnancy. So women would receive it while they were pregnant to protect their newborn babies. And there's ongoing research regarding this, and this does look like a very potentially very effective way of preventing this disease. But actually there's another approach which has been taken in America. And this has nothing to do with vaccines. This is where all pregnant women get a swab during pregnancy from the vagina and the rectum to see if they're a carrier of Group B strep. And if those women are a carrier, then they get antibiotics, penicillin, during labour to protect their baby. And this has had a dramatic effect in reducing the incidence of Group B strep. This is something that could be done in the NHS and isn't being done in the NHS. And this is a matter of ongoing debate. Do we want to be giving antibiotics to 20 to 30% of women in labour or not? And what are the trade-offs? And there's legitimate arguments on both sides. And there is actually a campaign from a charity called Group B Strep Support that is campaigning for routine screening and antibiotic use to reduce the numbers of cases. As we said, there were 508 neonates last year who had this disease, and there were 38 deaths in UK and Ireland. But the rest of this talk is going to be about this last group. This is called meningococcus. So all these are bacteria, different bacteria. They can all cause meningitis and septicemia. And you can see the numbers of these three are not that dissimilar in children. Meningococcus causes 724 cases in the last year, of which just over 400 were in under 18-year-olds. So it's not that dissimilar. But this is the one that tends to get the publicity. This is the one that's been in the news lately about the vaccines that may or may not be given, and this is one that caused the disease in young Faye. And partly it's the name, I think, meningococcus, and also, Matt Dawson and his son. It causes this very distinctive rash where you get bleeding into the skin, and this is the famous glass test that every parent knows about. If your child has a rash, you put a glass on it, see if it fades or not, and if it doesn't fade, that's a risk that shows that it could be this very nasty infection because there's bleeding into the skin. This actually comes from the septicemia part of the illness, not meningitis. It's called meningococcus, so it also has that. It sounds like meningitis, and it is partly as simple as that. Very visible, distinctive rash, and it can affect previously well children, and tragically they can be dead within 1 or 2 days from their first symptoms. And it does affect primarily young children, but it can affect older children and teenagers and cause outbreaks in schools. So it gets a lot of media publicity regarding that. And importantly, there's been recent developments in the area of vaccines, which is what I've been involved with and why I'm talking to you today. So firstly, there's just to understand what I'm going to be saying, we need to get a head around the meningococcus alphabet. That there's 6 different types of meningococcus that can cause disease in humans: A, B and C, W, X and Y. And their relative prevalence differs in different parts of the world. Until recently in Africa, it's all been about serogroup A. As it happens in Europe, it's mostly been about serogroup B and C. But this changes over decades and over time for reasons we don't understand. We're going to be focusing on England and Wales, on the UK, where you can see, first thing to say is that in the UK, it's been mostly about serogroup B. That's this blue colour. We've got the fairly faint and small up there. You can see the different types here, different serogroups. And you can see it also affects primarily young children, under 1 year of age or 1 to 4 years of age. You do see a little second peak in 15 to 19-year-olds here, And just bear in mind that these age ranges are much broader. So this is 20 years of age range here, 20 years age range here versus 1 year age range here. So when you're looking at the incidence. But this is what we're talking about. In terms of mortality, in children it's about 5%. It goes up a little bit in teenagers and then up higher in the elderly if they do get it. Such that we're talking at around 130 deaths per year over a 4-year period here. So it's about, 130 deaths over a 4-year period in children under 4 years of age. So around 30 deaths a year from this bacteria. For the survivors, there's high rates of majority of survivors will have some sequelae, whether it's scarring on the skin, or learning difficulty, or amputation. Especially with the septicemia, you can have death of the limbs that require amputation. Okay, so this is what's been happening over the last decade or more for meningococcus in the UK. First thing to say is, around the turn of the millennium, we're seeing B and we're seeing C. And you can see that C's gone away, which is fantastic news. And you can see that the overall incidence has declined significantly. What's happened? First thing to say is that a vaccine was introduced against serogroup C in 1999-2000. And this vaccine was based on the sugar coating, the polysaccharide capsule that surrounds the bacteria. And that's what defines these different letters that I'm giving you. Serogroup A has a different capsule to serogroup B, to serogroup C, etc., etc. And that's a great vaccine target for serogroup C. That was used as the basis of the vaccine that was introduced in 1999-2000 and resulted in this fantastic reduction in disease for serogroup C over the course of a few years. It just went away, and it has stayed away. It's not come back. But we've seen some, and you can see this story, this graph tells us two other things. Firstly, it tells us it's mostly been about serogroup B, and I'm going to come back to that later. But there's been this more recent story about serogroup W, such that this now accounts for about a quarter of cases, and that's new. As B's gone down, C's disappears, B's gone down, W has emerged, such that if you look along these graphs here, this is the cumulative incidence. So if you look at this purple line, this is the cumulative number of cases of men W in 2012 to 2013, then the next year, and then the year after that. There's an invasive strain that's been introduced from South America, as it happens. It's causing high rates of disease and a more outbreak, and actually a higher fatality than most strains. So there were 24 out of 130 cases in 2013-14 were fatal. And this is occurring across the age range. So yes, it is occurring in young children, but it's also occurring a lot in teenagers and in the older, older populations as well. You can see this dramatic increase. And slightly atypical presentations, they often present just with vomiting and diarrhea, look like they've got a gastroenteritis, and then progress very quickly to more serious illness. And so you can just, was just published a few weeks ago, describing 15 cases, short history of vomiting, diarrhea, and then, unfortunately, 5 of those 7 had died within 24 hours of reaching hospital. Now, the good news is we've got 2 vaccines that work against serogroup A, C, W, and Y, so it covers all 4 of them. Again, based on this polysaccharide capsule. And last year it was announced that an ACWY vaccine was going to be given to all teenagers in school at around year 8 and 9. And this is a fairly complicated schema given as to when this is going to be introduced, depending on different both cohorts. But basically, secondary school students are going to get a dose of the MenACWY vaccine. So this is good. And also people going to university. So even those leaving secondary school going to university, because it's recognised there can be outbreaks, are going to get this vaccine. But of course, that raises the question, well, that's just going to cover this lot here. In fact, a fairly small group of that. What good is that going to do? But as it happens, this may well, the expectation and the anticipation is that this will actually have a knock-on effect to all the others. Because about 20% of the people in this room will be carrying meningococcus in their throat. It sometimes causes disease, but majority of cases it's caused, mostly it's just carried harmlessly in the throat, especially in late teenager, early adulthood, kind of late school, early university age. And by targeting this group, we know that the vaccine can reduce the carriage of these bacteria in the throat. So the hope is, and the expectation is, that by targeting this group with the vaccine, that you'll be getting protection to all the other age groups as well over the next few years. So it's kind of a more targeted approach to have a broader effect. This happened with when the Menc vaccine was introduced. Menc was given to teenagers, and that's the dark blue line here, those that got the vaccine. But then the others that never got the vaccine, you also saw a decline in disease because it was no longer circulating in the community, that bacteria. Okay, so the obvious question is, what about a vaccine for serogroup B? Why has this taken so long and why has it been so hard, given that we've been here? Now, I was working at St Mary's intensive care unit for children in 1999-2000, and was seeing so much serogroup B, and that's part of the reason I came up to Oxford to look into vaccines for serogroup B. The challenge has been, though, that unlike the other vaccines, the serogroup B capsule here is rubbish at inducing a good immune response. It's a very poor vaccine candidate. You can't make a vaccine out of it. And so there's been a decade or more, 2 decades, of trying to find a good target that would protect against serogroup B. And they've gone down to the next layer in this bacteria, which is called the outer membrane. This has got lots of proteins in it. So it's not a carbohydrate now, it's proteins. And these vary a lot between different bacteria, between different Men-B bacteria even. So it's been more of a challenge to find a good collection of proteins that will provide reasonably broad coverage. And as it happens, after decades of work, 2 vaccines have recently been licensed. I'm going to be talking about this one because this is the one that's just been introduced into the UK last year. And this contains 4 key proteins that provide reasonably good coverage across Men-B bacteria. Now, we were involved in the development of this vaccine. It was manufactured and developed by Novartis Vaccines, a pharmaceutical company. We're in collaboration with them. We're doing lots of clinical trials such that actually we gave the first dose of this vaccine to any child anywhere in the world in 2006. And since then have enrolled over 1,400 participants to clinical trials of this vaccine, predominantly children. So again, a wealth of information about how well a vaccine works. And what we know from those clinical trials is that the vaccine can induce a good immune response. This is looking at this graph here. The darker orange is children that have had a full immunisation course, tested against multiple different strains of the Men-B bacteria to see how well they can kill that bacteria. And you can see reasonably good coverage for some of the strains. The children didn't develop antibodies that were able to kill those bacteria, and that's interesting. And we also know that it doesn't interfere with existing vaccines. That's good. We also know that about 2/3 of children that got this vaccine developed a fever. That's quite high for modern vaccines. This is a vaccine which we would call it reactogenic. It induces a decent amount of local reactions and systemic reactions like fever. The vaccine was licensed in January 2013. That was great. But you can see what's happened here is that even without a vaccine, Men-B disease has dramatically decreased from where we were in the turn of the millennium. It's gone away. We don't fully understand this. It may be related, surprisingly, to the changes in smoking, the laws about smoking in public places, because if the carriage of meningococcus in the throat is clearly related to smoking. If you smoke, you're more likely to carry. The fewer people are smoking, and then maybe this is why it's driven a decline in carriage. That's good news. Fewer people getting disease. But suddenly, kind of the debate had shifted. We're not having as much of this disease as we used to. And we see that on the wards. We're not seeing as much as we used to. And so the decision about whether to introduce this vaccine or not, and any vaccine in the UK, belongs to a group called the JCVI, the Joint Committee for Vaccines and Immunisations. And they are mandated to make a decision on cost effectiveness. They have to decide, is this a good use of NHS resources or not? And this is where it gets tricky. The disease had declined in incidence, but it does cause devastating illnesses. And it does, as it has with this girl, cause sequelae, even for the survivors. Now, the criteria they use is something called QALY, Quality Adjusted Life Year. That's 1 year of perfect health. And the guidelines, well, they started at 30,000, that the threshold that the NHS should be spending to gain a 1 year of QALY is £30,000. That was subsequently reduced to £20,000. The rules changed slightly. So that's the price of 1 year of perfect health. And they did some interesting calculations, which actually calculated all that using this vaccine, giving a child this vaccine when they're a baby, would only prevent about a quarter of their lifetime risk of meningococcal disease. And I think that gave us a lot of pause to think, really, is that true? And they decided that on these calculations that this vaccine would not be cost effective at any price. The manufacturer could give this vaccine to the NHS and it would still cost the NHS too much money, just in the cost of administration. So the decision at that time was that this vaccine would not be used. And what was interesting actually is that this caused far less publicity than the recent problems, the recent issue that's been in the news. This kind of came and went without too much of a protest. The decision, they said it would only prevent a quarter of disease. That was because, as you can see here, it doesn't protect against all strains of MenB. Children developing antibodies that will kill some strains, but not all of them, of the MenB bacteria. And you also saw quite a rapid waning, this from the test that we were doing. A child had a peak of antibodies at 13 months, and then by the time they're hitting preschool, those antibodies have mostly gone. And so you may well need another booster. And that's one of the things that came into effect. So declining immunity, less than full coverage. It's predicted it would cover about 3/4 of MenB disease in the UK. There was some outcry, there was petitions raised, and that was an interim analysis, and so they gathered more information, and with that further information and a bit of recalculation and a bit of this and a bit of that, they then decided, okay, actually, well, we have now could make this cost effective. If the manufacturer would sell it to the NHS for £3 a dose, which is nothing when it comes to vaccines, the list price for this vaccine was £75 a dose, then this would actually now be cost effective. And that, I think, at least started the discussion. And from there was then negotiations with the manufacturer. He's not the most popular man in the NHS at the moment, but there he is. He's put his face to this one and to say, we are going to fund the introduction of this vaccine. The price they've negotiated is confidential, it's not disclosed, but there's a kind of a bit of a budget introduction here, because instead of, it's licensed to give that you give babies the dose at 3 doses, one at 2 months, one at 3 months, one at 4 months of age. They said, actually, we'll try and get away with a bit less. So we're just going to give 2 doses and a booster dose at 1 year of age. And most vaccines, when they're introduced, have a catch-up campaign. So this is where it gets a bit contentious now. They've decided to introduce the vaccine, but a limited introduction, and it will only be given to babies born after the 1st of May 2015. And of course, Faye was born before that. And this is where it gets really tricky. To work out, is this a reasonable thing, that we're just going to know that some children will get sick, but this is not worth the NHS putting money into. And hence this petition, most signed petition of this format that's gone to Parliament, over 800,000 signatures saying we need to expand the use of this vaccine and we need to give it at least up to age 11 is the figure that was provided. And this was discussed. Now, this is breaking down the distribution of this disease in more detail per year and per age group. And if you look at the grey columns, this is the most recent data. This is from 2014 to 2015. And you can see about 100 cases in England and Wales in under 1-year-olds, and actually 130 cases in 1 to 4-year-olds. But again, that's 3-year 8 cohort, so it's only about 30 or 40 per each year. So you have to immunise an awful lot more children in order to prevent those 140 cases versus those 100 cases here. And as for the up to 11 years of age, you can see that fairly quickly you're getting down to much smaller numbers in 5 to 9-year-olds and 10 to 14-year-olds and throughout the rest of the age group. Bit of a blip here in teenagers, as we know, for this bacteria. And so this has been where the decision has come from. And there's been some very clever people working on this. This is their job, health economists looking at this, doing models to work out amount of money spent from number of lives saved. And they run these models, and this is a model that's run over 100 years, so 100 years of NHS spending, so some element of expectation they can predict the future. But if you give this vaccine, as has been introduced, at 2, 4 and 12 months, the feeling was that over 100 years you'll prevent 59,900 cases. And that's 1,300 deaths averted, 1,340, at a cost of £13 billion. This was, they used a hypothetical price. If you included that with a catch-up campaign to just 1 to 4 years of age, so this is now including Faye and Matt Dawson's son and others that have been affected, you're preventing about what is that, 1,600 more cases over 100 years with a 6 billion extra spend. And so this is where it is tricky to try and work out, with actually very few deaths averted, about 50 deaths averted. And this can be represented graphically, slightly different things here. We're looking at a blue line, which would be as if we were giving it at 2, 3 and 4 months. So this is the number of cases averted, the annual number of cases going on from the vaccine introduction to 100 years. And it's all about these 10 years here. If we're using it as we are, this is the decline that you'll see. If we'd included, where is it? Included in the brown line a catch-up campaign to just 4 years of age, then you would see fewer number of cases, and then after 10 years it's levelled off. And that's the discussion as to whether to expand the use of this vaccine or not. What has been happened is this has gone back to Parliament, and the decision has been made not to expand the use of this vaccine. But I think the bodies looking at this, the JCVI, will be looking for evidence of how well this vaccine works, because I haven't really emphasised this enough, that we actually don't yet know if this vaccine works or not. We know that it induces a good immune response in babies, they develop antibodies, but the UK is the first country in the world to use this vaccine, and we will be the first to gain data as to whether it actually works or not. And that'll be becoming available over the next few months as we look for a fall in the number of cases in those babies that have had the vaccine. And so I think this is going to be an evolving story over the next year or two to see how well a vaccine works, and then to go back to the calculations again to look to see whether we can afford this vaccine or not. So just to summarise of all of this, there has been much done over the last 20 years to prevent meningitis and septicemia. We do see far fewer of this than we used to, far fewer cases than we used to. The majority of the remaining cases are due to these 3 bacteria, pneumococcus, for which there are vaccines that are providing 80% coverage, not brilliant, but pretty good. Group B strep that happens in babies and could be partially preventable by increased use of antibiotics, but there are vaccines in development. And what we've just been talking about, meningococcus, 2 vaccines recently introduced. One, MenACWY for teenagers, that was thought to also likely to provide protection to a broader age group, and then MenB for children born after May. And the evidence for this will be coming available in the coming year, and that then will inform future vaccine policy both in the UK and globally. And I think this is going to be a fascinating story as it unfolds, and yes, there have been some very hard decisions that have been made. I'm just going to obviously take any questions that you have, but just also to mention that, as I said, I work with the Oxford Vaccine Group. We have got a standout in Tinchwick Hall, and we're currently doing and recruiting to paediatric studies for vaccines against these bacteria and virus, and also for adult studies. And there's fascinating studies going on looking at new typhoid and paratyphoid vaccines, and if anyone's interested in those, they can get information about them at our store just out in Tinchwick Hall. But of course, I'll be happy to take any questions you might have.